Okay, in our video series of cardiology lectures, in this video, we are going to talk about a very high yield topic, aortic dissection. We are going to talk about its presentation, its causes, diagnosis, and management of aortic dissection in detail. A 65-year-old hypertensive male presents to the emergency department at night with a severe chest pain. Patient tells you, the doctor, my chest pain is extremely severe. It's a tearing chest pain. The chest pain is radiating towards the back between the scapula. Patient also has neck pain and jaw pain. Patient, when you examine the patients, when you check the blood pressure in the left arm is 60/40. When you check the blood pressure on the other hand, the right hand, you check the blood pressure and you find out that the patient's blood pressure is 190/120. Patient is having asymmetrical blood pressure, different blood pressure in both arms. Then the next thing you do is that you order an ECG and you order the chest X-ray. When you receive the chest X-ray, you see a widened mediastinum. You observe the mediastinum is wide. This is a classical presentation of a patient with aortic dissection. Patient will present to you with tearing chest pain, a chest pain that will mimic like an MI, and many times it will happen that the patient is concurrently also having an MI and also having aortic dissection at the same time. This shows the importance of ordering chest X-ray whenever you order an ECG in any patient with chest pain. Patient is also having asymmetrical blood pressure in both arms. This is the classical presentation of aortic dissection. What is aortic dissection? How do you diagnose it? How do you manage it? Now we are going to talk about it in detail. First of all, you need to understand that there are three layers in the artery or in the vessels. First of all is the tunica externa that forms the outer layer. Then is the tunica media that forms the middle layer. And then the innermost layer is tunica intima. Tunica intima forms the innermost layer and that is covered by a basement membrane. So the innermost layer is tunica intima of the artery. What happens in the aortic dissection, that the patient gets a tear in the tunica intima, and whenever patient gets a tear in the tunica intima, blood starts entering between tunica intima and tunica media. This is another picture showing the intimal tear. Whenever there is a tear in the tunica intima, the blood starts gushing inside and the blood starts accumulating between the tunica intima and the tunica media. This is aortic dissection. If you understand this picture, you can totally understand the concept of aortic dissection. The blood is accumulating between the tunica intima and tunica media due to a tear in the tunica intima, which is the innermost layer of the vessel. Aortic dissection is a tear in the inner layer of the aorta that leads to progressively growing hematoma in the intima media space. In the intima media space, the hematoma, the blood starts accumulating, and remember, it starts spreading upwards and downwards, and throughout the vessel there will be a huge tear where the blood is accumulating, and this is what is causing increased size of the mediastinum, because the vessel is now divided into two vessels. There are two vessels at the same time, and that is causing increase in the size of aorta. Tear in the inner layer leading to a progressively growing hematoma. That is aortic dissection. It most commonly occurs in old age groups from 60 to 80 years of age. Our patient that presented in the case initially had 65 years of age, and if it rarely occurs in the young patients, but in the young patient, if it occurs, it most commonly occurs if there is a connective tissue disease like Marfan syndrome, like Ehlers-Danlos. If there is a connective tissue disease in a young patient, that makes the young patients prone to aortic dissection. But remember, it's most common in the elderly. It is more common in males as compared to females. Most important risk factor, most common cause of aortic dissection is hypertension. Whenever you get a patient who is 60 to 80 years of age and patient is having aortic dissection, always choose hypertension as a cause, because hypertension is the most important cause of aortic dissection. Other than that, there are other causes that can also lead to aortic dissection, like trauma, a decelerating injury. Patient had a car crash, patient was going on a speed 140 or 150 and suddenly he collided with another vehicle. That can result in aortic dissection. Now you will be thinking that how can a sudden deceleration injury can cause aortic dissection? Basically what happens is that this is our aorta and these are the vessels arising from aorta. As soon as left subclavian artery takes off the aorta, this area is called as aortic isthmus. Remember, aortic isthmus is fixed to the other structures in the chest. Aortic isthmus is the most fixed part. Now what happens is that when there is sudden decelerating injury, in the sudden decelerating injury, the other parts of the aorta that are not fixed, they slip ahead and it causes a tear in the intima, and that tear would lead to aortic dissection. Most common area that is fixed is aortic isthmus, and this is the area which is most prone to tears. Other than that, syphilis causes inflammation of the arteries, and that inflammation of the arteries can result in aortic dissection. Cocaine, how can cocaine cause aortic dissection? Cocaine rapidly increases blood pressure and it causes hypertension, and it can result in severe tear in the intima of the vessel. Other than that, if a young patient comes to you with aortic dissection, always think of a connective tissue problem like Marfan syndrome, Ehlers-Danlos, and bicuspid aortic valve in Turner syndrome. Always remember, smoking is a very huge risk factor for aortic dissection because smoking damages the tunica intima of the vessel. Now, aortic dissection is classified according to Stanford classification, Stanford A and Stanford B. If the aortic dissection involves the ascending aorta from its origin from the aortic valve to the brachiocephalic artery, this is called as Stanford A aortic dissection. And look how has been a tear in the vessel and blood has accumulated in between the intima and media, and the vessel has increased in size. This is Stanford A, ascending aortic dissection. A for ascending. Stanford B, whenever the aortic dissection occurs from aortic isthmus or after the left subclavian artery originates, this aortic dissection is called as Stanford B aortic dissection, and that is a descending aortic dissection. So Stanford B is descending, Stanford A is ascending aortic dissection. There is another system of classification of aortic dissection that is called as DeBakey classification, but it is not very important. You should only remember the Stanford classification. Now, the pathophysiology is very simple. There is a tear in the aorta intima, and that tear would lead to blood gushing out and accumulate between the tunica intima and the tunica media. Blood enters the media of the aorta and forms a false lumen in the intima media space. Now coming to the clinical presentation, the classical clinical presentation of aortic dissection would be a severe tearing chest pain and the chest pain radiating towards the back between the scapulae. Patient will be having asymmetrical blood pressure in the both arms. The patient will be having sudden severe tearing or ripping pain, anterior chest pain, back pain. The back pain can be between the scapulae, interscapular pain, or it can be a neck or jaw pain with hypertension or hypotension. Now at the same time, our patient was having asymmetrical blood pressure. At one side the patient was having hypotension and on the other hand the patient was having hypertension. How does this happen? Now we'll explain that as well. Now this is a very important slide. Make sure to listen each and every word that I am saying right now. This is the left atrium, this is the left ventricle, this is aorta arising from the left ventricle. Now if you see, there has been a tear in the tunica intima and blood is gushing out and it is accumulating between the tunica media and tunica intima, forming a false lumen. The aortic dissection has started. There is aortic dissection over here. Now slowly and gradually this false lumen will start increasing in size and it will spread to this vessel. This first vessel is brachiocephalic artery, the brachiocephalic artery that is supplying the right hand. The brachiocephalic artery is supplying the vessels of the right hand. Now as soon as it reaches the brachiocephalic artery, what will happen is that this false lumen, there is a huge amount of blood in this false lumen. This blood will block this vessel. This blood will block this vessel and it will result in lowering of blood pressure on the right side of the hand. So on the right hand, blood vessels will be blocked because this aortic dissection has now spread and involved the brachiocephalic artery, and this blood has blocked the passage of blood towards this vessel. Therefore you will see hypotension in the right hand, but it has yet not reached the left subclavian artery. So the left subclavian artery is still receiving enough amount of blood, and this is happening while the patient is having hypertension, because as we said that most likely patient is having hypertension, and hypertension has led to this tear. So this vessel, the left subclavian artery, is receiving enough of the blood. So in the left hand you will see high blood pressure, the blood pressure of 190, and in the right side you are having blood pressure of around 60, because the right brachiocephalic artery has been blocked by this aortic dissection. Now coming to the second very high yield point. Now as you know that aorta exits the left ventricle, and as soon as it exits the left ventricle, it gives rise to coronary arteries, those coronary arteries that are supplying the heart muscle. Now what do you think that if aortic dissection is taking place, and if there is a false lumen forming, and what if it involves the coronary arteries? When this aortic dissection involves the coronary arteries, the coronary vessels are blocked, and when the coronary vessels are blocked, patient will have an MI. MI is a complication of aortic dissection. Many times you would see that the patients would come to you with chest pain, and that chest pain is due to aortic dissection, and on ECG you would see an MI. Many times patient will be having MI and aortic dissection at the same time. Now what if this aortic dissection involves the carotids? If it involves the carotids, it will block the blood flow to the brain. Many times patient would come to you with aortic dissection with neurological symptoms. Many times patient will be having strokes with aortic dissection at the same time. Stroke is a complication of Stanford A aortic dissection. You must remember these points. Now another very high yield complication that can happen in patients with aortic dissection. What if there is a tear over here and this false lumen starts bleeding in the pericardial space? Sometimes there can be a tear over here and blood can start accumulating in the pericardial space between the heart and the pericardium. When the blood accumulates between the pericardium and the heart tissue, that is called as cardiac tamponade. When cardiac tamponade takes place, there is blood surrounding the heart and heart cannot relax. Therefore, these patients would come to you with overt hypotension, severe hypotension. And that severe hypotension is very dangerous. These patients must be referred to surgical unit as soon as possible. These patients need urgent management if they present to you with hypotension, because that might indicate that that patient has developed cardiac tamponade. And that cardiac tamponade can be lethal in these patients. That hypotension can be lethal in this patient. So you must remember MI, stroke, cardiac tamponade as a complication of Stanford A aortic dissection. Everything makes sense when you understand the key concepts. If you know these key concepts, nothing can stop you from understanding aortic dissection, from dealing with all these patients, diagnosing all these patients. When you know what is going wrong with the body, everything goes right in its place. Now you know why there is asymmetrical blood pressure in both limbs. Patient can have syncope due to hypotension. Patient can have syncope because the aortic dissection might have involved the carotids and blood flow to the brain is also blocked. Remember, if a patient presents to you with chest pain, and with chest pain patient is having neck or truncal pain, or patient is having neurological features, or the patient is having syncope with chest pain, or acute limb ischemia where there are no pulses in one limb, severe pain in one limb, this is an indication that that patient is developing aortic dissection. Because chest pain with neurological features, syncope, limb ischemia, truncal pain, these are classical features of aortic dissection. Must have a low threshold for screening patients for aortic dissection. Now coming to the diagnosis of aortic dissection. Whenever you suspect a patient has aortic dissection, the first thing you should do is that you should start the initial test. The initial tests are easy tests that can be performed on the bedside. They include chest x-ray, transthoracic echocardiography, POCUS, point of care ultrasound. That is a type of ultrasound that is performed in the emergency unit rapidly or quickly. So if with these initial investigations, you can easily find out that the patient is having aortic dissection or not. But remember, these are not very sensitive tests. But since they are easy to perform, therefore they are performed in the emergency unit. In the aortic dissection, the chest X-ray would show a widened mediastinum. Now, how would you know that the mediastinum is wide? You measure the mediastinum. The mediastinum is measured at the aortic knuckle, and the mediastinum, if it is greater than 8 cm, this indicates that that patient has aortic dissection. Another sign is calcium sign. In calcium sign, normally the old patients have calcified aorta. Now, what will happen in aortic dissection, since the vessels will be enlarged, the vessels will be huge, this calcium sign will move outside and it will be located outer over here. If the calcium sign moves from this place to another place, and that is 6 mm away, that indicates that that patient might be having an aortic dissection. But remember, a normal chest X-ray does not rule out aortic dissection. So you cannot rely on these tests, because as I said, these are easy to perform tests. Therefore they are the initial tests, but they are not a confirmatory test for aortic dissection. Now, what is the confirmatory test for aortic dissection? The confirmatory test, the gold standard test with 100% sensitivity, 99% specificity, is CT angiography. CTA is the main test for the diagnosis of aortic dissection. CT angiography takes time, therefore it is generally performed in patients when they are stable. Now, this is a picture showing CT angiography, and if you see, this is aorta, and see the false lumen, see the tear in the intima that has started the blood to accumulate between the intima and media space. This is another picture showing the aortic dissection. Look at the tear, and look at the tear. This is aorta coming out, and this is the descending aorta. Look how the tear has spread from ascending to the descending aorta. This is a beautiful picture showing aortic dissection. This is another picture showing aortic dissection, a CT angiography showing aortic dissection. This is another section where you can see the aortic dissection, the false two lumens, two vessels, therefore the vessels appear huge, the mediastinum appear huge. Now, coming to the treatment and management of aortic dissection. Whenever a patient of aortic dissection comes to you in the emergency department, you must always perform chest X-ray, transthoracic echocardiography, point of care, ultrasound, must do ECG in this patient. In whatever patient you are having chest pain, you should always do ECG, and you should always do chest X-ray, always. You should do coagulation panel, you should perform the metabolic profile. Then after that, you need to control the blood pressure and control the pain. These patients will be having severe tearing chest pain. You must give morphine to these patients, control the pain, control the blood pressure. How do you control the blood pressure in aortic dissection? I'll be talking about it in a while. After that, once the patient has stabilized, only then go for CT angiography. If you are unsure about the diagnosis, you have to confirm the diagnosis by CT angiography, but till the time patient is not stable, you cannot perform CT angiography. CT angiography will tell you that whether it is ascending aorta, aortic dissection, Stanford A, or it is involving the descending aorta, the Stanford B. Now, if you find out that it is a Stanford A aortic dissection that is involving the ascending aorta, you must immediately go for surgery, because these patients are the one that will develop complications like MI, like strokes, like cardiac tamponade. They will get hypotensive after some time. Immediate surgery is indicated in patients with Stanford A. If the patient is having Stanford B dissection, which is involving the descending aorta, in such patients you can treat them conservatively, where you just control the blood pressure with beta blockers. But in Stanford A, you go for immediate surgery. Remember, if the patient is having hypotension, even if it is Stanford B, usually such patients are patients for surgery. Now, how do you control blood pressure in these patients? You control, if the patient is having hypertension, you give beta blocker like esmolol or labetalol. Esmolol 250 to 500 microgram per kg IV bolus over 1 minute, then 25 to 300 microgram per kg per minute IV infusion, and you titrate accordingly. Or you can give labetalol 20 mg IV bolus, then 20 to 80 mg IV every 10 minutes. You control the heart rate, you slow down the heart rate, you reduce the pressures, you reduce the stress. Now, after beta blocker, you give the vasodilators. But what if you cannot give the beta blockers? What if the beta blockers are contraindicated? If the beta blockers are contraindicated, then you can give calcium channel blockers. Verapamil and diltiazem can be used. After you have given the beta blocker or you have given the calcium channel blocker, after giving these, you have to give a vasodilator. Beta blockers are followed by vasodilator like IV sodium nitroprusside 0.25 to 0.5 microgram per kg per minute. IV infusion is given. The target is to bring the blood pressure down to systolic 120 or 110. You must control hypertension in these patients, because if you don't reduce the pressure, it can cause the spread of aortic dissection to the rest of aorta, and it can even result in complications. If the patient has hypotension, hypotension is dangerous in aortic dissection patients. Hypotension can be lethal in these patients. These patients need surgery, even if it is a Stanford B aortic dissection. You must give IV fluids to these patients. You give vasopressors if the patient does not respond to IV fluids like norepinephrine, phenylephrine, and you should avoid ionotropes. Ionotropes like dobutamine should be avoided to maintain the blood pressure, because these patients, you need to reduce the stress on the vessels. Therefore, ionotropes are avoided. IV fluids and vasopressors are given, and these patients need to be consulted for surgery. Surgical managements include open surgery with polyester graft implantation. They open up the vessel and they place a graft inside. Or endovascular stent placement can be done, where they place a stent at the place where there has been a tear and the false lumen has been formed. So stent placement can be done, or open surgery involving a polyester graft can also be done. So whenever you have a patient with aortic dissection, you perform chest X-ray or ultrasound, or do thoracic echocardiography, you do ECG, you do coagulation panel. The next thing you do, you control the blood pressure. If the patient is hypertensive, give beta blockers followed by nitroprusside. If the patient gets stable, the next thing you do is you do CT angiography, and after CT angiography, you classify whether that is Stanford A or Stanford B. If Stanford A, refer for surgery. If Stanford B, you can treat that conservatively unless the patient is having severe hypotension. If you suspect aortic dissection and the patient is also having MI or stroke, now as we know that for treatment of MI and stroke, we do thrombolysis. We give tissue plasminogen activator. So in such cases where the patient is having aortic dissection, for the treatment of MI and stroke, you cannot do thrombolysis. Thrombolytics are avoided in such cases. If you want to learn the treatment and management of MI and stroke, I have explained them in detail in my video on MI and stroke. You can check out the link of those videos in the description below. The complications of aortic dissection include malperfusion syndrome, where the vessels are getting blocked. As soon as the aortic dissection is spreading in the vessel, in the aorta, it is blocking all the vessels. That will result in malperfusion of the body. If it is Stanford A, it can result in MI. Aortic regurg can occur, a very high yield point. Aortic regurg can also take place in Stanford A. Cardiac tamponade, stroke can occur. How do you prevent aortic dissection from happening? Screen the patients for blood pressure. Old patient blood pressure control is very important, and smoking cessation is very important. Prognosis of aortic dissection, there is 9 to 39% in hospital mortality in USA, but in developing countries like India, Pakistan, Bangladesh, the mortality is way higher than this. If you liked my video, please click on the subscribe button and make sure to check out my other lectures on cardiology section, neurology lectures, emergency medicine lectures. I have all the playlists on my channel, and you can also support us on Instagram and buy me a coffee. We talked about what is the aortic dissection, intimal tear leading to blood accumulation between intima and media space, more common in male. In old age people, if young, there will be a connective tissue problem, hypertension being the most important cause, smoking. Aortic isthmus can be involved in traumatic tears, classification, the pathophysiology, the clinical presentation, how it can result in cardiac tamponade, MI, stroke, how there is an asymmetrical blood pressure, chest pain. With these findings, suspect aortic dissection, do these tests, CT angiography being the gold standard test. The widened mediastinum seen on chest X-ray, normal chest X-ray does not rule out. This is the CTA. When you perform CTA, you classify Stanford A. Stanford A needs surgery, Stanford B treated conservatively. Hypertension treated with beta blocker followed by vasodilator like nitroprusside. hypotension treated with vasopressors, IV fluids, and refer for surgery. Surgery includes open surgery and stent placement. MI stroke with aortic dissection, avoid thrombolytic therapy. Complications of aortic dissection, how to prevent aortic dissection, and prognosis of aortic dissection. If you like my video, make sure to click the subscribe button and check out my other videos on my channel. Thank you very much.